All right, let's talk about one of the most common numbers in all of medicine, your blood pressure. Seems simple, right? But what if I told you that behind those two little numbers, there's this whole story of common mistakes, a really intense medical debate, and even a question about what healthy really means? Let's dive in.
So here's a big question. Is the single most common medical test out there actually done wrong a lot of the time? I know it sounds kind of crazy, but the evidence really points to a surprising yes. The way your blood pressure gets measured, whether it's at home or in a clinic, might not be giving you the real story. And, getting it wrong, the consequences are way more serious than you think.
So check out this number, 20. 20 millimeters of mercury. That's how much your reading can be artificially pumped up by really simple, super common mistakes. I mean, we're talking about stuff as minor as crossing your legs or having a quick chat while the cuff is on. And a 20-point error, wow, that's enough to take a perfectly healthy reading and turn it into a diagnosis of stage 2 hypertension. That's a big deal. A diagnosis that could lead to medication, major lifestyle changes, all based on a bad number. It's a life-altering mistake.
Yeah, let's just call this what it is, the 20-point mistake. And it's a huge problem, happening all the time, leading to wrong diagnoses and treatments that might not even be necessary. So what are these little slip-ups that can throw your numbers off so bad? I mean, look at this list. Talking, slouching in your chair, not taking your sweater off. These aren't some huge medical blunders. They're just normal things people do. But every single one can add up to a totally inaccurate reading. And this is exactly why the new 2025 guidelines are so focused on just getting the basics right every single time. Okay, so we've laid out the problem. Now, what's the solution? Well, thankfully, there is one. The 2025 clinical guidelines have laid out this really clear, standardized 3-step process. It's designed specifically to get rid of these errors and make sure the number you see is a number you can actually trust. So it all breaks down into 3 key stages. First up, preparation. This means no caffeine, no smoking, no exercise for at least 30 minutes beforehand. Also, empty your bladder, and this is a big one, just sit and rest quietly for 5 minutes right before you take the reading. Okay, second stage, positioning. You need to be sitting down with your back supported and your feet flat on the floor. The cuff goes on your bare arm, and your arm should be supported at about the level of your heart. And finally, step 3, technique. You got to use a validated device, and this is absolutely crucial. Take at least 2 readings, a minute or 2 apart, and then average them. This isn't just being picky. It's what it takes to get a real, accurate result. All right, so we know how to do it right. But now let's get into the why. There's a really specific logic behind these rules, especially when it comes to one very, very common point of confusion. You've probably been there, right? You measure the pressure in both arms, and the numbers are different. So which one is your real blood pressure? Which one counts? Is it tempting to just pick the lower one, because it feels better? Or is there something else you're supposed to do? Well, the answer is actually really clear. The medical guidelines are firm on this. You always use the arm that gives you the consistently higher reading. Now, why is that? It's because going with the lower number gives you this dangerous, false sense of security. The higher number, that's the one that gives a more accurate picture of your cardiovascular risk. It's the one that truly shows the maximum load your heart and arteries are dealing with. And this all comes down to a really crucial principle, which is basically this. Underestimating your blood pressure is way more dangerous than overestimating it. The entire system is built to avoid missing a case of hypertension, because the consequences of undertreating it are so much worse than maybe overtreating a slightly high reading. And here's a perfect example of why that principle is so important. When we look at strokes, about 85% of them are ischemic. That means they're caused by blockages, which are often linked to the long-term damage from high blood pressure. Only about 15% are the other kind, hemorrhagic, caused by bleeding. So since uncontrolled high blood pressure is a major driver of the far more common type of stroke, making sure we don't undertreat it is the absolute #1 priority. Okay, but here's where the story takes a really interesting and complicated turn. Let's say you do everything perfectly. You follow every single rule. You get the most accurate reading possible. Well, even then, there's a huge ongoing debate among the top experts about what your target number should even be. You've basically got 2 camps. On one side, you have what's called the moderate goal. This is aiming for a blood pressure under 140/90. For a long time, this has been the widely accepted, safe, effective target. But on the other side, you have the intensive goal, which is aiming for under 130/80.
This is a newer idea designed to squeeze out every last bit of risk reduction, especially for people who are already at high risk. And these two different philosophies represent a really fundamental disagreement in medicine today. And the impact of this debate? It's massive. When the US guidelines officially shifted to that more intensive goal, less than 130 over 80, the percentage of American adults classified as having hypertension jumped from about 32% to almost 46%, literally overnight. Just like that, millions of people were suddenly reclassified as having a medical condition. Now, as you can imagine, this shift set off a lot of alarm bells. Critics immediately started arguing that this would lead to massive overdiagnosis, labeling perfectly healthy people as sick. In fact, some really big medical groups, like the American Academy of Family Physicians, they initially refused to endorse the new lower target. They questioned the quality of the evidence and warned about the real danger of overtreatment. And at the heart of that concern is this concept called the J-curve phenomenon. It's a theory, and it's backed by some pretty compelling evidence that suggests if you lower blood pressure too much, too aggressively, you can actually hit a point where the risk of things like heart attacks starts to go back up. It's like there's a sweet spot, and pushing past it might actually be dangerous for some people. So with all of this complexity, you've got measurement errors, you've got competing guidelines, you've got this intense medical debate. What's the personal bottom line? What does this all mean for you? Let's just boil it down to some clear, actionable takeaways.
Okay, first things first, which arm to use? Always the one with the consistently higher reading. Remember that. Second, which number really matters? It's the average of many readings over time, not your one single lowest reading. Third, what's a safe starting point? For most people, aiming for under 140 over 90 is a moderate, safe goal. And finally, should you be chasing the lowest number possible? Absolutely not. The goal is to get your average into that target range.
And really, this all points to one critical theme. The goal has to be personalized for you. These guidelines, they're the starting point. But the right approach for you comes from a conversation with your doctor, where you can balance these universal rules with your own unique health profile, your risks, and your personal goals. And that really leaves us with a final, pretty big question to think about. As the science keeps moving forward, maybe the biggest question isn't just what is your blood pressure, but what should it be? Thanks for joining us.